While anorexia and bulimia are frequently discussed, binge eating disorder affects 2.8% of U.S. adults, towering over the other two combined. That translates to millions of adults, making BED the most common eating disorder in the country. Despite its prevalence, it stays out of the spotlight. Culturally, these symptoms are dismissed as simple overeating or written off as a failure of willpower. This creates a paradox in public health. Millions of people deal with the same condition, but because society rarely names it properly, it remains hidden from everyday conversation. When society labels a medical condition as a discipline problem, patients start to believe it. Those dealing with BED internalize that message, feeling as though they are personally defective or broken. That leads to an isolating reality: years of secret binges, followed by the routine of hiding wrappers and evidence from family and friends. Expending mismatched energy to hide the physical evidence makes it difficult for patients to speak up and seek medical intervention. A paralyzing wall of shame stands as the primary barrier to treating the country's most common eating disorder. Overcoming that barrier starts with the medical facts. BED is a recognized DSM-5 diagnosis, and evaluating it requires a licensed clinician. The criteria start with a timeline. A binge involves consuming an unusually large amount of food within a discrete period, typically under 2 hours. During this window, the patient feels a subjective sense of a loss of control. To reach a formal diagnosis, these episodes and the accompanying distress must occur at least once a week for 3 or more months. Crucially, BED requires the absence of regular compensatory behaviors, like purging or overexercising, distinguishing it from bulimia. These diagnostic criteria describe a measurable neurological and behavioral condition, detached from the concept of personal discipline. Because the symptoms are so specific, clinical science has built targeted treatments. The gold standard is CBT-Enhanced, a protocol developed specifically for eating disorders. If emotional dysregulation drives the binge pattern, clinicians deploy therapies adapted from dialectical behavior therapy to help stabilize those emotional spikes. Medical management is also an option, including pharmacotherapy like lisdexamfetamine when overseen by a medical professional. Many patients experience ADHD, depression, or anxiety alongside BED. Treating these co-occurring conditions improves long-term recovery outcomes. Progress requires engaging with a structured, multi-pronged clinical science that has strong outcome data. Clinical protocols are only effective if a patient feels safe enough to access them. Telehealth functions as a clinical tool to dismantle the shame barrier. It allows patients to discuss bodily trauma from the safety of their private space. Providers can initiate this care remotely using brief, validated screening tools like the BED-7. The digital screen acts as a shield against shame, transforming an isolated room into a clinical environment for healing. This remote approach is how coping and healing counseling operates. They are an eating disorder-informed telehealth practice serving all 159 Georgia counties. Their team includes a diverse group of over 15 licensed therapists, including LCSWs, LPCs, and LMFTs, trained to deploy evidence-based care. To increase accessibility, they are in-network with Aetna, Cigna, BCBS, United Healthcare, and Humana. Medicaid patients receive care with a $0 copay. You can initiate the recovery journey by visiting chctherapy.com or by calling 404-832-0102. Encouraging disorder is a treatable medical reality. The path to reclaiming control begins exactly where you are sitting right now.